So what we're looking at here is an abdominal radiograph of a skeletally mature patient. The first thing that jumps out at me is the dense calcifications projected over both renal outlines, especially on the left. Now, these calcifications aren't scattered randomly. They've got a medullary distribution, meaning they're focused in the renal pyramids, which is pretty classic for medullary nephrocalcinosis. The kidneys themselves look to be of normal size, and while the outlines are a bit obscured by bowel gas, I'm not seeing anything that would suggest something more sinister like a mass or obstruction. That said, this calcification pattern strongly suggests medullary sponge kidney, MSK. In this condition, the renal collecting ducts are dilated, which predisposes patients to develop kidney stones. And speaking of stones, there's also something else we need to talk about: the plastic stent we can see. Its proximal end is in the mid-left ureter, but it's also extending down to the bladder, indicating it's migrated. Along with that, we see a row of calcifications in the distal left ureter, which is very characteristic of Steinstrasse, or a stone street, of calculi. So what's going on here? This is a case of medullary sponge kidney with migrated ureteric stent and Steinstrasse formation. Now, the next steps would include discussing this case with urology to figure out what to do about that stent. I'd also recommend an ultrasound to check for any hydronephrosis, just to make sure the kidney isn't getting backed up with urine due to the stent migration. Now let's think about what questions the examiners might ask you on this case. They could easily start by asking, what are the causes of nephrocalcinosis? Of course, medullary sponge kidney is a big one, but they're probably going to expect you to mention other causes too, like hyperparathyroidism, renal tubular acidosis, or even papillary necrosis. It's important to be able to differentiate between medullary and cortical nephrocalcinosis because the causes for each are pretty distinct. In cortical cases, you're usually dealing with conditions like chronic glomerulonephritis or transplant rejection. They might also ask, what exactly is medullary sponge kidney? Here I'd explain that it's a congenital condition where the renal collecting ducts are dilated, which predisposes the patient to form kidney stones. It's typically bilateral and can present with a bunch of grapes appearance on imaging, which is a key detail. They may want to test your knowledge on rare associations like Beckwith-Wiedemann syndrome or Caroli's disease, although these are rare. Now, with that migrated stent, examiners might dig into the complications that can arise. I'd mention things like obstruction, infection, and the formation of Steinstrasse, which is what we're seeing here. The next logical question would be, how do you manage this? Well, in this case, you'd want to confirm whether there's any hydronephrosis, that's where the ultrasound comes in, and then discuss with urology whether the stent needs to be repositioned or removed. And of course, they'll likely ask about treatment options for the stones. In this case, you'd be looking at options like shockwave lithotripsy or ureteroscopy, depending on the size and location of the stones. If the stent migration has caused a lot of obstruction or discomfort, it might need to be addressed surgically or removed altogether. So to summarize, this case of medullary sponge kidney with migrated ureteric stent and Steinstrasse formation requires immediate discussion with the urology team, imaging follow-up with ultrasound, and likely some form of intervention for both the stones and the stent. If this helped clear things up for you, be sure to subscribe to Radiology Made Easy. We've got plenty more cases to tackle together. See you in the next video.